Okay, so we're gonna get started now, and for everybody listening, this is the first time that I'm doing a podcast in Sin Pelos en el Cactus, but in English. And today we have a colleague, a friend, somebody that basically got me started on all this stuff. And he's the author of the Obesity Code, the Diabetes Code, the Guide to Intermittent Fasting. And his book, I mean, despite some people criticize it, has helped, I mean, hundreds of my patients here in McAllen, Texas, which is the most obese city in the United States, for 6 years in a row. So, yeah, I mean, and we're going to touch about this because I think that the book from Dr. Fung, the Obesity Code, is something that basically people can digest it. And by being able to digest the knowledge, they're able to implement the knowledge and change their life. So, Jason, thank you so much for being with me in this podcast, and I look forward for your teachings and how you can reach the Hispanic community.
Well, thanks so much. Thanks for having me here. It was great to be here.
So let's start. I mean, we were talking about this, and as I said, I thought I had discovered the Holy Grail because in 2017, I mean, I'm doing all of my teachings or what that was taught to me in med school. And I'm going with, hey, I'm going to, my Cheerios, and I'm staying away from fat, and I'm always hungry, and I'm gaining weight, and I'm starving myself, and I feel like shit. And so I started exploring different things. One thing led to another, and that was low carb, and then low carb led to fasting, and then I thought I had created the Holy Grail. And then before I knew it, well, there's already a book published in 2016, I believe, with everything here, with you letting us know about this, you know. So how did you get started with this?
Yeah, so it was, I think my journey was much the same as yours. So I'm a kidney specialist. I'm a nephrologist. So I treat a lot of type 2 diabetes, and it's been increasing over the years. And so after a while, around 2008, 2009, there was a couple of studies published, which was the Accord and the Advanced studies, which showed that just giving a lot of insulin to people to get their blood glucose down didn't actually make them any better, which was a shock, actually. It sounds, it sounds so obvious now. But at the time, we really believed that if you just gave a bunch of insulin to people, 100 units, 200 units a day, and get their sugars down into the normal range, we'd save lives. But we didn't. And that to me was a very big surprise. So I started to think about that and how that really came about. And what always interests me is the sort of the pathophysiology behind why these things don't work. And that was sort of what got me started. So then I got really interested. So if just giving a lot of pills and meds and insulin to diabetics was not going to help, then what was going to help? And that's where I started to think about diabetes really heavily, because obviously that's what I treat a lot of. And it eventually came to me that, hey, type 2 diabetes, if you have diabetic nephropathy, which is the patients that I was seeing, which is diabetic kidney disease, the solution actually is not to treat them. If you treat them at that point, you're really almost too late. If you have diabetes, which causes kidney disease, then the answer is to get rid of the diabetes. And mostly it's type 2 diabetes, which of course at the time was complete heresy, of course, because people were saying that type 2 diabetes is not reversible. It's a chronic and progressive disease. So you probably remember this. And I said, that's complete idiocy. There's no possible way that is true. Everybody and their mother knows that if you lose weight, your diabetes gets better or even goes away. Everybody knew that. And yet, all the doctors, all the diabetes associations were saying, no, it's a chronic and progressive disease. Just take your pills and eventually you'll go on dialysis. And to me, that wasn't good enough, right? It wasn't the answer. It was obviously a lie. And I did a video, I think it was 2013, 2014, something like that. I called it one of the big lies of type 2 diabetes, that it's chronic and progressive. It's like, no, this is a reversible disease. And that changes everything, because if it's a reversible disease, you shouldn't be trying to just medicate it. You should be trying to reverse it. As physicians, that's what we should have been trying to do, but we were not taught to do that. So that's where I became very interested in the question of weight loss, because again, we're trying to, take this back to the root cause. So you start with diabetic nephropathy. Then you say, well, you don't want to treat that. You want to get rid of, you want to treat the type 2 diabetes. Then you say, okay, well, if you want to treat the type 2 diabetes, then you got to lose weight. So how are you going to do that? So that's where I started really spending a lot of time looking at weight loss, what causes weight loss. And like pretty much all doctors, we're taught that it's all about calories, right? Calories in, calories out. And the whole point of that is that it's not actually true. Like, it doesn't actually work. There's been hundreds of studies over the years, and every single one of them points out that cutting calories, like just counting your calories and cutting calories, which is a standard way that we all got taught as doctors, right? Eat 500 less calories a day, you'll lose a pound a week. It doesn't actually work. Everybody knew it didn't work, and that's why doctors didn't try to get people to lose weight, because what they knew about it was so spectacularly unsuccessful that they basically gave up. So as a profession, we gave up on it and told Weight Watchers and Slim Fast, and we gave it to all these other commercial companies, when we should have been trying to help people, because it's so important to the health of our patients, right? You can't just give it up. It's really, really important. And the reason why the whole calories thing didn't work, and it's, so not only did all the studies show that counting calories and cutting calories didn't work, like virtually everybody's done it already, right? It was rare that you found somebody that didn't try cutting calories. So they lost weight for 6 months, then they put it back on plus an extra 5 pounds, right? Happened to every single person that I met. So if it's so unsuccessful, and again, the studies bear that out, like the probability of success of getting somebody to lose weight like that was like, 1%, 99% failure. So as physicians, like, why would you recommend a treatment strategy that has a 99% failure rate? Like, nothing in medicine we give has a 99% failure rate. And yet, for one of the most important pieces, which is weight loss, we were giving advice that was horrible, like just horrible. And the reason it doesn't work is because our bodies don't work like that. In fact, our body has, it's got sort of a mechanism to sense how much body fat we have. So people who talk about calories in, calories out, they think that the amount of body fat is simply, you eat a certain amount of calories, your body burns a certain amount of calories, and the rest is dumped into the body fat. It's not like that. The body actually has very sophisticated mechanisms to adjust whether or not, like, how much body fat you have. So think of a thermostat, for example. So if you have a house, you set a room temperature, right? If it gets too hot, it turns on the air conditioning, cools it back down. If it gets too cold, it turns on the heat, warms it back up. But it's always maintaining that steady, temperature. Body fat is the same. Our body wants to have a certain body fat percentage. And if you eat more, your body will actually burn more calories. Okay, so they've done the studies. Rudy Leibel in 1995 published a very, very good study in the New England Journal of Medicine, which is probably the most important journal in medicine. And he showed that if you basically force feed people to gain weight, when they gain 10% extra body weight, their bodies burn 16% more calories per day. They're kind of burned off. So your body has set this weight. If you go up, they'll burn it back down. And if you lose weight, your body will burn less so that you go back up to that weight. And we know a lot of these mechanisms. For example, if you gain weight, your body fat goes up. Your fat cells will secrete leptin. Leptin goes to the brain, activates mechanisms to make you not hungry. If you think about a time, say you go to a big wedding, you had a huge meal. Are you really hungry? Like, you had a huge, massive lunch. Are you hungry at dinner? No, because your body has mechanisms to sense when you should eat, when you should not eat. So it's very sophisticated. It tells you when you're hungry. It tells you when you're not hungry. And if you ignore those signals, it will turn up the amount of calories you burn, and it will turn down the calories you burn. So it has this set weight, which is controlled by hormones. So the question is not, eat fewer calories, eat more calories, because if you go up, they'll go back down. If you go down, it'll go back up. The question is, why is your body fat thermostat set at the wrong level? Why is it too high, right? That's the important thing. And that's where you have to look at the hormones. And there's different hormones, but one of them, for example, is insulin. That's one of the key hormones that we talk about all the time. And, we know that it's not just about calories, because calories doesn't, like, the body set weight. If you set your, if your thermostat is set sort of too high, it's the same thing, right? If it's controlled by hormones, you have to fix those hormones. If your body fat is set this high and you try and go down, your body will try and adjust it back up, which is why it never works if you just focus on the calories, because the calories wasn't the one that's controlling the thermostat. If you think about a room, for example, you might say the same exactly. You make the same analogy. Suppose you say the room temperature, the temperature in your room depends on heat in minus heat out, right? So now you say, well, I want to warm it up, so I'm going to bring in a little portable heater, put an extra heat in. The temperature of the room will go up, right? Wrong. Absolutely not, because the temperature is set. You bring in heat, right? Heat goes up. The body turns on the air conditioning, pushes the heat back down, right? Same thing with calories. You try and force your body, your set weight is here, you force your calories down, it pushes it back up, right? So that existence of that thermostat means that you can't just focus in on the calories. You have to focus in on what that level is. And that level is always controlled by hormones, because hormones they run everything in our body. And I always talk about that there's other hormones that are important. For example, sex hormones, for example. So if you look at children before puberty, boys and girls are roughly the same in terms of body fat, right? After puberty, boys have a lot more muscle and girls have a lot more fat. They have about 50% more fat. And that's because their body is getting ready to have babies. Well, if you think about calories, you say, well, why are girls have 50% more fat? Is it because they have no willpower? Is it because they're having too many calories in and too few calories out? No, that had nothing to do with anything. Obviously, the amount of fat that you carry is set by your hormones. So not just insulin, but say testosterone adjusted the boys' bodies to carry more muscle and less fat. The girls' hormones with the estrogen and progesterone adjusted to carry more fat, especially in the hips and the waist. That's just normal. Had nothing to do with willpower, calories, exercise. None of that makes any difference. And it's the same, for body weight. Your body weight's set at a certain level. You must adjust it up or down in order to get successful weight loss. And that means focusing in on the insulin, on the cortisol, on the sex hormones, on all of those sort of things, which of course will impact the calories. Because, for example, if you adjust your body weight down and now your body's saying, oh, you don't eat, you're not hungry, obviously you're going to eat fewer calories. But it wasn't that you ate fewer calories, it was what was controlling you eating fewer calories, right? It's not the calories in, calories out, it's what's controlling the calories in, calories out, right? You're going that
I think that's, let me interrupt you there, because I see some comments here, and part of the reason that I invited you here was to clarify to all these fucking haters, you might say that he doesn't know what he's talking about, but I guarantee you, when you start simplifying things like this, it might sound that he doesn't know, but I can tell you that the recommendations that he actually tells people to follow have had the greatest impact on my patients as a interventional cardiologist. And so what he's saying, he's putting in a dumb level for many of you guys to understand that don't understand shit like you, the dude that was commenting here. So let me put it this way. It's like we have it in the science. So if we have two twins and they're both 200 pounds, well, one is 180 and the other one was 250. But now we have the 250 pound guy and he goes down to 180. Well, staying at the 180 like the other guy, now this guy's going to be struggling. He became more efficient burning calories, and that is science. his ghrelin, appetite hormone, is going to go up. His leptin, his satiety hormone is going to go down. So now the dude, to actually be at the same rate that his twin was at 180 pounds, he actually has to work 20% more harder, either burn 20% calories more or eat 20% calories less in order to stay just like his twin. So what Jason is saying in a very simplistic manner is for you guys to understand it, dumb it down. And I'm quite pissed that he gets so much criticism. And that was one of the questions that I asked him. How do you deal with this bullshit? Because I'm very verbal. I mean, he's more collegial and he shuts the hell up. Me? Go fuck yourself. I mean, it's like, honestly, it's a bunch of bull to a bunch of people that he's helped. And I think, you know what? If you don't like his teachings, I honestly don't care. You can leave this place, you know. But the point here is, he also put it in another. We can go back to the Biggest Loser story. We have the participants who lost, I don't know how much weight, like 100 pounds, 150 pounds, but they were doing a hypocaloric diet. When they did a hypocaloric diet, their metabolism probably dropped another 40%. So now that they go back to reality, back to life, well, they're hungrier because their ghrelin went up, their leptin went down, and their metabolism went to the shithole. So now when they tell you, Doc, I'm eating less and I'm gaining weight, that's not bullshit. It's actually the truth. But what Jason here is saying is basically simplifying the concept that sometimes we as physicians, we need to simplify it so much for people to understand it that we're going to get criticism like I have by other colleagues. We just stop giving a shit, you know, because we know that we're helping patients. An important point that you mentioned about the insulin. Well, we think that insulin is great. When we start going back to studies from 1930s, 1940s, there's a very interesting study where they had a dog, which I don't think they would authorize some of those studies anymore at this point in time. But they were actually infusing insulin in one leg while they were infusing normal saline in the other. And what did they see? That in a couple of weeks, the leg that was getting the infusion of the insulin, those arteries started getting atherosclerosis. It started getting thicker. And there's different mechanisms in which insulin will actually will create atherosclerosis. It will increase the smooth muscle by their growth factors. So it's extremely interesting. We're not saying that insulin is the only hormone. We're saying that this is a symphony of multiple hormones that are actually leading to obesity and the struggle of. Actually, Jason, I'm an interventional cardiologist, but after reading all this stuff and being fascinated by all this stuff, I also went and I certified myself with the American Board of Obesity Medicine. And of course, you have to digest a lot of bullshit that you don't believe in. It's like me studying for the boards again. It's like when you start reading the shit that you have to read and you have to implement on the patients, you might not agree with it. It's the pain in the ass. But, the thing is, the definition of insanity is trying the same thing, expecting a different result. And I think you got to the point in which you're a nephrologist, your complication was chronic kidney disease, stage 1, stage 2, stage 3, you see them advance, and boom, end-stage renal disease, now they're in hemodialysis. Me? Well, we start with atherosclerosis, CAD, stable angina, unstable angina, and boom, you have a heart attack. And we start seeing heart attacks in people with 35. So I see people with end-stage renal disease in their 30s. It's like, what the hell? That takes a lot of effort to screw yourself up to get to that point. So,
and the point is that the point about insulin is very good, because if you think about it, like if you think about causes of obesity, because if you say, why am I obese, right? What caused it, right? If you're looking for causes, everybody tries to complicate things, but it's very simple, right? If you want to say X causes obesity, simple. You increase X, do you get obese? Yes or no? You decrease X, do you get thin, right? That's causality, right? If you say calories, I just give people more calories, do they get obese? And in fact, they don't, which is very interesting, because they've done these studies. They've done these force-feeding studies where they give people 5,000, 6,000 calories. So, and it doesn't cause obesity. Why? Because as you give those calories, their body is trying to burn it all off. When you stop force-feeding them, they become so anorexic that is, they don't want to eat. Their weight just goes right back down. That's been shown, like, I don't know, there's multiple studies. So Ethan Sims he did a bunch of studies in Vermont, actually. So he was, and this is a very interesting story. So Ethan Sims, he tried to make rats obese. So he gave them a lot of food, but he didn't make them obese because once they ate enough, they stopped eating. So he said, oh, what about humans? Surely I can just make them obese, right? This was in the 60s. So he took a bunch of college kids and says, eat a bunch of food. I want you to gain weight. Not a single one gained weight. So they're like, oh, okay, well, maybe because they didn't eat as much. So then he went to the prisons. And again, you can't do these studies now. So they took the prisoners and they monitored, they made sure they didn't exercise more, and they force-fed them to gain weight. And they were feeding them like 10,000 calories a day in order for them to gain weight. And in that study in 1995 by Rudy Leibel, where he force-fed these people to gain 10% body weight. So if you're 100, remember, these are not obese people. So 160 pounds, you gain 16 pounds. He's forcing them to eat about 5,000 to 8,000 calories a day, right? We're not talking about like 2,200 calories versus 2,000. You have to eat like 8,000 calories a day in order to gain weight. Why? Because your body's burning it off on the other side, right? And so if it's not, there's no causal effect there, right? Increased calories, mostly you don't get long-term weight gain. If you decrease calories, you get long-term weight loss, right? That's the ultimate test of causality. And this has been done multiple times. Virtually everybody in North America has done this. Cut your calories, do you lose weight? No, because you get more hungry, right? And I'm not talking about the mechanisms. You can say, well, they didn't stick to the diet. You get more hungry. And so then what you do is your body simply decreases the amount of calorie it burns, right? This is exactly what happens. So say you normally eat 2,000 calories a day. You go to 1,500. You start losing weight. Your body senses the weight loss. And if you stay at 1,500 calories, your body will now drop how many calories you burn down to 1,400, for example. So as you do that, you're starting to regain that weight, even as you maintain that weight, that 1,500 calories, right? So calories is not causal to obesity. On the other hand, take insulin. If you give somebody insulin, do they gain weight? 100% they do, right? I can make anybody fat, right? I just give them enough insulin. If I gave you 100 units a day, starting today, you would start to gain weight. Everybody does. So therefore, we have a causal effect. I give insulin, causes obesity. What if you reduce insulin to very low levels? You see this in Addison's disease for cortisol. You see this in type 1 diabetes for insulin, right? So cortisol is the same. If you give somebody prednisone, which is synthetic cortisol, do they gain weight? 100%. That's a causal relationship. If you take away insulin, like type 1 diabetes, what happens? Untreated type 1 diabetes, they basically lose weight until they die, right? So that's a causal effect. So if you want to find out the cause of obesity, you don't have to futz around like complicated. It's all calories. Yes, maybe eventually it gets to calories, but the root cause is the hormonal change that led you to eat more calories or burn less calories, which has adjusted that thermostat up, right? And you give insulin, give insulin, it adjusts your body weight up, and you gain fat because you just told your body to gain more fat. There was a great study.
You know what? If something I think that the people would actually, with your concept, this goes basically with the Kraft curves. So by having the Kraft curves and the insulin resistance, so maybe you can explain a little bit about that. The Kraft curves, because the way I see it is, as a cardiologist, people will struggle to lower their triglycerides if they're type 2 diabetic and they are injecting insulin. You're done. That's fixing your triglycerides when you are taking insulin. And watch out, people. I want to clarify, because you sometimes put words in our mouths that wouldn't say. We're not saying you to stop the insulin. This is what your physician needs to be doing. He needs to be guiding you on how on earth you're going to require less insulin. I'll give you more.
Yeah.
But with insulin resistance, with pre-diabetes, your body is producing so much insulin that it gets to a point that you've got so much resistance that you now require to put more insulin. And insulin is like a building hormone. So now you're making more triglycerides, and now you've got your fatty liver, and triglyceride is deeply associated with a cardiovascular disease, and so is insulin resistance. So, I mean, if you think pertinent, maybe we can focus on how the insulin resistance starts developing and how this affects. And another question before I forget, I read a study because I have found 4 different mechanisms in which insulin will actually increase or give you hypertension, which actually goes with the people or the diabetic people or pre-diabetes or diabetics getting insulin. So endothelin-1, vasoconstrictor, it goes up. Nitric oxide goes down because it basically screws up the pathway. Growth factors related to insulin make the smooth muscle get thicker, so less compliant, thicker vessel. And I read something, but some nephrologists tell me it's bullshit, but there's a publication there. I read about specific insulin receptors in the kidneys that will make the kidney absorb more sodium and water.
An proximal tubule.
Okay.
So if you're absorbing more salt and water, it's basically the opposite of a diuretic, which is used to lower blood pressure, right? So you're actually raising pressure. For sure, that's been known for years. I actually learned that in medical school. But yeah, instead of insulin resistance, what I do is I call it hyperinsulinemia, because I think the concept is much more easy to understand. So if you think about what obesity is, it exists along the spectrum of type 2 diabetes, right? So if you think about it, obesity in many cases, not the only case, because remember, there's a lot of different hormones at play here, right? There's insulin, but there's also cortisol, there's also sex hormones, there's also GLP-1s and GIP and all this stuff. But if you just focus on insulin, we know that most people who gain weight, they're in a hyperinsulinemic state, right? So they're producing a lot of insulin. And I think that's the primary cause of their weight gain, because the foods that they're eating, so some foods stimulate insulin more than other foods. If you eat very often, you're going to stimulate insulin more than if you don't eat often. So the dietary change that happened caused people to have higher insulin levels. That higher insulin levels basically ratcheted up the body set weight so that we gained weight, because that's insulin's job. Insulin's not a bad hormone, but it does a certain thing. If it's too high or too low, any hormone is bad, right? So as you ratchet up insulin, your body says, okay, well, that's like ratcheting up your body fat thermostat, right? So we're going to gain more weight. So that's what obesity is. What happens if you follow this whole cascade is that insulin is going to put glucose into the cells, right? We know insulin acts at the insulin receptors, open the GLUT4, cell receptor. Glucose then goes into the cell. Now you think about the cell, right? So as you have persistent hyperinsulinemia, so insulin is high and stays high, you're pouring glucose into the cell, right? Because the insulin's high, the glucose is higher, eating a lot of carbs, got a lot of insulin. So the cell is just filling up with glucose, right? It's getting bigger and bigger and bigger. It's just like if you have a suitcase. If you have a suitcase and you put in, your clothes, it goes in fine. But as it fills up, it's harder to push more stuff in. That's what insulin resistance is, right? Your cell, which is taking all this glucose, is now completely full. So even though insulin is there, the glucose cannot get into the cell because it's full. That's basically insulin resistance. So your body senses this glucose and says, oh, I need to make more insulin. And sure, that works for a while, just like if you have a suitcase and you shove it down, right? So you shove it down, then you can close it. But then you stuff more shirts in and you keep shoving it down with more and more force. So this is what happens to the body. It's shoving extra glucose into this cell that's already full. And as it keeps filling up, as it keeps shoving more glucose in, it has to keep producing more insulin to keep shoving it in. And then the cell is getting bigger and bigger. So as insulin resistance gets worse and worse and worse, you reach a point where you can't shove it in anymore. And that's where the glucose stays out the cell, and that's why you have type 2 diabetes. So instead of insulin resistance, what you can see is that hyperinsulinemia, or too much insulin in the blood, and insulin resistance are the same thing. But if you call it hyperinsulinemia, that is, the disease is that insulin is too high, then you can say, well, how am I going to treat that? Well, figure out a way to lower insulin, which is low carb, which is things like intermittent fasting. But you can also use drugs like SGLT2s will lower insulin, and they have fantastic effects. And GLP-1s lower insulin a lot. They basically crush your insulin to very low levels by causing all this nausea. Well, if insulin is high and you're giving a drug that lowers insulin, that's good. And that's why you're seeing all these heart benefits. You're seeing kidney benefits with SGLT2s, GLP-1. But the problem underneath the whole thing was too much insulin. So let's follow this through. So if you have too much insulin, and this cell, this liver cell, for example, is friggin' filled with all this glucose, it's like, what am I going to do with it? Well, it then activates a process called de novo lipogenesis, which is going to create fat. So it takes the glucose in the cell, which is so full, right? And now it creates fat. But it doesn't want to store fat in the liver because that's, the liver is not a place to store fat. So now you've got, so hyperinsulinemia went from obesity to hyperinsulinemia to prediabetes to diabetes. Now you've got fatty liver, which all falls from the same process, the pathophysiologic process. You're creating all this fat, so you get fatty liver. Now your liver doesn't want this fat, so what does it do? Well, it shuttles it out. We know this. What does it shuttle out with this? Triglycerides, VLDL, right? That's how the liver gets rid of the fat. So it says, okay, the liver says, I have way too much fat. I need to get rid of it. So I'm going to package it with these proteins called VLDL, which are triglyceride rich, right? And send it out into the blood so it can get to the fat cell where it's supposed to be stored. So what do you see? High triglycerides in the blood, which then causes low HDL, right? So now you have hypertriglyceridemia as part of hyperinsulinemia, low HDL as part of hyperinsulinemia. Then what happens? Well, all these cells start to take up the fat, and you get fat deposition all around the abdomen. So you get abdominal obesity, right? So now what do you have? You have abdominal obesity, high triglycerides, low HDL, type 2 diabetes or high glucose, and as we mentioned, hypertension. Those 5 things are the exact definition of metabolic syndrome. The ATP definition of metabolic syndrome has 5 things. Every single one of them is caused by hyperinsulinemia. You can follow the whole process. So all that insulin resistance, you think, people think that it's bad for you. Well, it is. But remember, the reason the body does it is because it's trying to protect itself at every step, right? You're putting in too much glucose, right? Too much insulin, too much glucose. So your cell gets too big. Eventually your cell says, I can't take anymore. I need to stop it, right? That's why you're developing the insulin resistance, because the cell is trying to protect itself, right? Then the body says, I don't like the glucose in the blood, so it makes more insulin. Then you get fatty liver, right? Because the body's like, I have too much glucose, let me make some fat. Now the liver tries to protect itself by shuttling all this fat into the triglycerides, which is why you get the high triglycerides, low HDL. And the other problem is that hyperinsulinemia is going to cause atherosclerosis, right? We know this. 100% we know this. There's multiple mechanisms that shows that how insulin causes all this scarring and the thickening and all this stuff. So people say it's all about LDL cholesterol. Like if you compare the effect of metabolic syndrome versus high LDL, they're nowhere close to each other. Like the metabolic syndrome is like at least 5 times as bad as the LDL. Like if you look at the how much risk each one is, like diabetes as a risk factor versus high LDL, they're not even close. Like metabolic syndrome is like way worse for you. So this is the whole process. And then you get back to this thing. Well, what started the whole thing in the first place? Well, it was all too much insulin, which can be changed by the diet. So that's where you have to fix things, because that's your root cause. Yes, it's been a long way. Like you went from, your diet to hyperinsulinemia, to obesity, to type 2 diabetes, to fatty liver, to hypertriglyceridemia, to atherosclerosis. That's the change. But the part at the very beginning is the diet. And that's why it's so important, because You can give drugs at all those other steps, but unless you fix the actual root cause, you're not actually going to be as successful as you want to be for your patients. So all these doctors are like, focused on, oh, what drug should I give? It's like, well, that's okay, but you got to focus on the root cause.
Which brings me to the point. So for me, that advice, and I think more and more for people eating 3 times a day in your freaking snacks. I mean, you just mentioned it. And the problem is, what are snacks? Your snack is not a boiled egg. Your snack is not healthy food. The snack is usually a piece of shit processed crap that is going to stimulate your glycemia, that is going to increase insulin. So the point here to the development of insulin resistance, the way I sometimes tell it to my Hispanic population, is imagine that you come here and I gave you a shot of tequila for the first time. Well, you're gonna get, tipsy. You're gonna get a buzz. But if I'm not giving you a shot of tequila 3 or 4 times a day, and I do that for a month, then you're gonna start developing tolerance. Well, the same thing goes when you're snacking, and if you're a receptor, you're gonna start glycemia, insulin, boom. Glycemia, insulin, boom. And all of a sudden, you start developing the resistance to the insulin, and then you start generating the hyperinsulinemia. And these elevated levels of hyperinsulinemia, they're just amazing how physiologically they affect in a negative way when they're in levels that you should not be at. For example, PCOS, that I know that you have I think you have a book with Nadia Patewana, right? And it's a fabulous mechanism on how you start changing the hormonal balance, and from being more from an estrogenic place, now the women start producing more testosterone, up to 50%, if I'm not mistaken, from what I've read in the study, depending on the hyperinsulinemia, which goes with the hirsutism and the symptoms from polycystic ovary syndrome. So the next step here is, you said lifestyle. So what we're trying to do here is, well, it's not only about demonizing the insulin, but it's what is causing the insulin to go, up, and all these hormonal changes. And here is when if eating 5 freaking times a day like a pig, well, then what do we need to do? Well, here comes the concept of fasting. But the problem is, fasting is something that some physicians, they cover up their ears like they heard Voldemort and Harry Potter, It's like, so the way I tell patients is, don't tell your doctor that you're fasting. Just tell them, I'm not hungry in the morning, so I skip breakfast. And then I eat from 10 a.m. to 6 p.m. Why? Well, because if I eat later, then that impacts my sleep. So when you change the way that you are mentioning or when you're addressing a particular thing, then there's no so much issue. We spoke about with Tro and Brian Lenskis about not saying low carb, saying modified Mediterranean diet. Nobody flinches. Everybody is fine with that, So
yeah, the fasting is fascinating because, when I started writing about it, people thought it was like the worst thing. Like, this, remember 2013. I started writing about fasting, intermittent fasting, because, the first time I heard about it, I thought, oh, what a bad idea. Everybody knows you have to eat all the time, right? Eat 6 times a day is better for you than anything. But as I started to look at the science, there's actually no science behind that. And if you think about it, like very, very basically, your body can store food energy, right? So food energy is calories. Your body can store some because, if you're a caveman or cavewoman, there are times that you're not going to have food. So therefore, your body has to have that ability to store some food on the body. That's calories, and that's body fat, and that's blood glucose, right? Those are the ways you store it. So you can take glucose and you can build it into a big chain called glycogen. You can shuttle it into the liver and you store it. You can take body fat, and that's a very easy to convert, but very sort of low capacity way to store energy. And then there's a sort of body fat, which is sort of unlimited in capacity, but has, more storage capacity. So you can store calories as glucose and fat, sugar and fat. If you don't eat, what is going to happen? Well, your body is going to use either the glucose that you've stored or the body fat that you've stored. And that's it. So if you have high blood glucose or excess body fat, then fasting is very, very, very good for you. Like, sure, maybe you might be hungry. I'm not saying that you won't get hungry. What I'm saying is that it will be healthy for you. If you have low blood glucose or low body fat, then no, it won't be good for you. If you're anorexic, like, some of these people from the 70s had anorexia nervosa, then no, fasting is very bad for you, right? Which is where people always get confused because they're like, well, I did it and it didn't work for me. It's like, well, you weren't the right person to be doing it. So, people are stupid because, people get on me all the time and they think that everybody should be fasting like 5 days. And it's like, no, if you're a 16-year-old girl who weighs like 85 pounds, then you should not be fasting because you are at a high risk of eating disorders and anorexia. If you are a 60-year-old man who weighs 400 pounds and is on 150 units of insulin with blood, an A1C of 9, then fasting could save your life. The girl, it could kill her. The man, 60-year-old man, his risk of anorexia nervosa is virtually zero. It's as close to zero as you can possibly get. He needs to fast. The other person doesn't. So fasting is just a tool. It has nothing, it doesn't say anything about, it's the skill in which you use that tool. So for the people that I treat, which are generally adults, generally older, generally type 2 diabetes, and generally overweight, then it's a very, very good tool. But what happens, of course, is that people who are like, athletes or they're, these bro science people, they're like, 4% body fat and like, I'm fasting for longevity. And it's like, it was terrible. Yes, it was terrible because you didn't know that you're not the one to do it. Maybe you need more protein because you're working out all the time. No, you shouldn't be fasting. But they don't actually talk to me. They just sort of say, oh, well, it's really bad. It's like, sure, it couldn't be bad for you. It doesn't mean that the 400-pound man with 60% body fat shouldn't be fasting. A totally different situation. So you got to think, okay, well, why is your body carrying body fat? Well, it's a source of energy. So let your body use it. There's nothing wrong with it. It's entirely physiologic. So, it's not that complicated. People make things so complicated. You must eat 3 times a day. You must eat this percent, this many grams of protein and this many carbs and this. It's not that complicated. If you have body fat, you can fast. If you have too much blood glucose, you can fast because your body has a source of energy right there. And if your body burns some of that glucose, it's going to be very good for you. And maybe we can take you off all these medications and reverse your type 2 diabetes, which is massively important for your health. Like, you cannot underscore how important reversing that. Like, diabetes is like the most important risk factor for heart disease, for strokes, for cancer, all these super bad things. I don't even think there's anything worse, right? For diabetes, they used to call it a heart attack equivalent, right? Because it raised your risk of heart attack so much, it's like having a heart attack already. It was a massive risk factor for all the things we mentioned before. So reversing it is massively important. And if your insulin's too high, how are you going to lower it? Well, fasting is one way. Low carb is one way.
Yeah, definitely. And this is fascinating because if in the past, if by following my Cheerios because they're approved by the American Heart Association and drops cholesterol, give me a freaking break. I've been trying to, and throughout my career, doing my best effort. Have you ever told me that I would be somebody, which I like to say, putting the diabetes in remission, because I just hate to deal with the bullshit of, oh, you're not reverting disease, that's wrong. Shut the hell up. So let's call it remission and go ahead, be happy. So, by reverting or putting it in remission, the point here is that I would have never thought, as an interventional cardiologist, that I would be able to start decreasing insulin, stopping insulin, and getting even to a point in which I have been successful in stopping diabetic medications. I'm not saying that I can do an endocrinologist job. I'm just saying that I have been able to, but I do assist my work with a multidisciplinary team, with endocrinologists, with dietitians, who we are all in the same page. Triglycerides is an example. Seeing triglycerides of 700, 800, it made you shit your pants. You go with fenofibrate, you go with Visipa, You try to decrease, but if you're taking just the tablets, but you did not make a modification to your lifestyle, which is going to make you burn more triglycerides, that shit is pretty much useless. I mean, it's going to be a couple of numbers, but you can drop it from 800 to 100. I mean, when I started seeing these things, I'm like, what the hell did I miss throughout my med school, throughout my training? Because I think you said it. We just throw the towel. I mean, we do not believe that we can actually create that impact on patients. But once you see that you can, that's the true definition of being a physician. It's not just treating the complication. For me as an interventional cardiologist, it was not satisfying. It was a pain in the ass, just me treating for a PCI or a STEMI or something. Just the same way that I'm going to treat you for end-stage renal disease with a hemodialysis. No, we want to avoid that from happening, or we want to delay it from happening if you're already in advanced stage. And by doing these changes, that is where we see this, and that is the things that I wanted to mention. Yeah. Which, by the way,
the thing is that the whole the actual ideas are actually extremely simple. Like I always say, they're always easy enough for doctors to understand them, because you didn't miss anything during medical school. I didn't miss anything in medical school. Nobody told us. In fact, if somebody told us different, we would have laughed at it. But think about this for a second in terms of, say, a low-carb diet. Okay, so here's the thing. If you're a type 2 diabetic, we know that your blood glucose is very high, right? That's how the diagnosis is made. Your A1C is high, your blood glucose is high. If you think about carb, what are carbs? They're glucose. That's just what they are. You eat bread, you eat rice, you eat potatoes, it's glucose. So chains of glucose, they're called polysaccharides because they're chains of glucose. Starches are polysaccharides, and they're arranged in, amylopectin and amylose. But either way, they're chains of glucose. When you eat them, your blood glucose goes up because you're eating glucose, your blood glucose goes up, okay? If you eat protein and fat, which is amino acids and triglycerides, your blood glucose doesn't go up because you didn't eat glucose, right? So we know this. This is not new. You can see this in the glycemic index. If you eat bread, your blood glucose goes up. If you eat an egg, your blood glucose doesn't go up. So here's the thing that's so, I don't even understand why it's not obvious. If some foods, carbs, raise your blood glucose, and some foods don't raise your blood glucose, protein and fat, and your blood glucose is too high, why wouldn't you just cut out the food that raised your blood glucose? Isn't that bloody obvious? Doesn't even a third grader with no medical knowledge be able to figure that out? You could figure it out from the glycemic index. You could take a whole glycemic index and say, here's the foods that raise blood glucose. Here's the foods that don't raise blood glucose. So the minute you add the no-carb foods, it's all zero, right? So the glycemic index actually doesn't apply to non-carbohydrate containing foods, because if you don't have carbs, it's practically all zero. So you could take a list of the glycemic index. These foods raise your blood glucose. These foods don't raise your blood glucose. You ask a third grader, well, if my blood glucose is too high, what should I eat? And he'll point to those foods that don't raise your blood glucose. Well, why is it more complicated than that? It's not. It's not actually that complicated. So why do we
make it complicated?
We make it complicated we bend ourselves into all kinds of contortions to try and explain why you should eat a lot of carbs, right? 50% carbs. That was the recommendation for ages, right? The recommendations actually changed. So if you look at the American Diabetes Association, everything has changed in the last couple of years. So you talk about remission. Mm-hmm. So prior to 2020, what was it?
2019, I think.
It was 2021. 2021.
You did?
Yeah, and the official was actually 2022. So 2020.
Because in 2019, they came out with a recommendation and saying that the low-carb lifestyle is...
Or low-carb for remission. They actually had a definition of remission in 2021. Yeah. Mm-hmm. So before that, people were saying, oh, you can't put it into remission. Now you can, because the ADA has basically said this is the definition of remission. So therefore, it is attainable. So therefore, people who say you can't put it into remission are completely wrong as of 2021, because obviously the establishment has changed. The guidelines, if you look at the nutrition guidelines from the ADA, they say low carb has the most scientific evidence of all diets. So cutting out your carbs is not some fringe position. It's actually what the experts have gotten together in a big meeting. These are consensus guidelines, and said the diet that has the most scientific evidence for treatment of type 2 diabetes is one that is very low in carbohydrates. So it's like sometimes you get out there and people attack you all over the place. And it's like, well, why don't you just read the ADA guideline?
Yeah.
Like, because they're stuck in the, 2010s or a lot of people in the 1990s with their low fat and all this stuff, right? And they're trying to attack you because they're like, well, cutting carbs no good, low carbs no good. You can't put it into remission. It's like, maybe you should be a little bit more up to date, because it totally can be put into remission, and cutting carbs is the best way that we know how.
For me, it's mind-boggling that statement, because it comes with everything that it impacts, the low-carb lifestyle, how it trumps the low-fat and blah, blah, blah. I mean, that is there in 2019 in that consensus PDF, but still people don't read it, because I think if they actually saw it, and I've made posts about it, but if they read, if they digest what that is saying, then saying low carb is not that controversial. But the problem is that people, when they say low carb, they associate it with just keto, and they associate keto with dirty keto, which is a piece of crap. I mean, a ketogenic diet can be a well-balanced, to a certain extent, vegetarian diet, which I hate, because you're not going to get me to eat tofu and tempeh and that bullshit. I mean, carne asada, you're not removing that from a Mexican, But this statement that you're saying about that, I mean, it's something that people still, we agree with it, well, everything with moderation. And when people tell me everything with moderation, I say, before you even regurgitate that horse shit, you have to know your patient and ask your patient, how difficult is it for you to moderate this particular food in a scale from 1 to 10? If moderating is high, I mean, it's difficult at 10, don't touch it. Don't eat it. You're already setting yourself for destruction. You have to set up yourself for success with foods that you cannot overeat. And those are usually the healthy ones. So they're usually the ones that they're not going to want to make you. They're not the processed ones. And we're not demonizing carbs. Vegetables are carbs. We're just saying we don't want you to go with the processed shit,
Yeah, the whole thing is that carbs are not the actual problem. It's the insulin, right? So if you have too much insulin, then yes, you have to see about the carbs. But the carbs come in all varieties, right? So there's lots of differences between carbs and how much they're going to stimulate insulin. So there's all these studies looking at different factors. So if you look at, say, the carbs that you get in refined products, it's much more, stimulates much more blood glucose. Glycemic index is much higher than if it's like beans or something like that. In fact, beans are actually pretty good. There's a difference in terms of the amylopectin. So amylopectin, for example, is the type of the structure of the carbohydrate. And there's amylopectin A, B, and C. So if you take refined wheat, it's amylopectin A, which is broken down very fast, and amylopectin C, which is in beans, which is hard to break down. What happens is that if the glucose is absorbed very, very quickly, like it spikes your glucose way up, it spikes your insulin way up. So if you change that, and instead of spiking way up, and you sort of take these sort of slower carbs, then you have a much less effect on insulin. So, they talk about, fiber, the same thing. It will slow the rate of digestion. So even amongst carbs, there are ways to change the carbs, mostly by eating them as unprocessed carbs, that are very different. So if you look at a glycemic index, Cheerios and highly processed wheat products, they're way up there. Whereas if you take natural sort of carbs that as they are in the ground, like a lot of vegetables, they're very low, even though they have carbs, right? Beans, they're fairly low in glycemic index compared to like white bread, for example. So it's not the carbs necessarily that is the problem. It's the insulin that's the problem. Like that's, your body doesn't care what kind of carbs you take. It only looks at the insulin effect, right? That's what it knows. It has receptors for insulin, not carbs. So that's the whole thing, is that you can still adjust it Same thing with, you look at in China, for example, in the 1980s, they're eating like white rice and vegetables all day long, right? 300 grams of carbs a day, no obesity whatsoever. Well, why? Well, they're not eating all the time, and they're not eating any sugar, right? So if you're not eating all the time, you're not eating sugar, then the effect is going to be less, because one way to modulate how much insulin you have is to eat less frequently. So they're just not eating all the time. The other thing is, of course, we eat for different reasons. So if you eat something all the time and you don't like it, then you're not going to eat for enjoyment, because you won't enjoy it. So remember in the 80s, so China in the 1980s was a very poor place, right? People making $1 a day sort of thing. So you're basically eating white rice and vegetables sort of 3 meals a day forever, like for your whole life. Not that much it's not that enjoyable after a while. So after a while, what happens is that you eat until you're full, then you don't eat because you're not enjoying it. So the minute you're not hungry, you stop eating. So therefore, yes, you can do fine with it because you're not eating all the time. You're eating carbs, but only enough to sort of get over that hunger. And then that's it. And you saw people were just very thin. Or you have a culture, for example, where like you look at Japan, right? Japan eats a lot of carbs. They eat a lot of rice. But you look at their culture, like their portions are puny, like really small and really expensive. So by the time you eat that portion, you're like, okay, I'm not that full, but I'm not going to spend another $60, for another portion because it's already expensive. So you just make do, and eventually your body, see, the thing is that you make do, and eventually your body says, okay, that's it, I'm done. I was going to get the rest of the calories from body fat or from blood sugar. And so they're very thin because that's their culture. So there are different ways to adjust. Like, it's not like carbs are everything. It's a very complex sort of thing because we're eating for different reasons. On the flip side, you have food addictions, which is a sort of increasing topic of increasing interest in ultra-processed foods, particularly. So people who eat or emotional eaters. So if people are eating for emotional reasons, that is, if they're a little bit depressed, say, we know that eating highly refined carbohydrates can light up your reward systems like dopamine. So if you're a little depressed, you might comfort yourself, comfort food, by eating highly refined carbohydrates. So if you're eating for emotional reasons and not for hunger, then you can't just say eat less, eat fewer calories, because the reason they're eating calories is because they're addicted or they're emotional eaters, and you got to fix that. Right? Fix the addiction or fix the depression, as opposed to just eat less. Right? But that's what I mean. You got to get to that deeper level of understanding. It's sort of like alcohol and alcoholism equals alcohol in minus alcohol out, right? And then people say, just drink less alcohol. That's the solution. It's like, no. Why are you drinking so much alcohol? Is it because you're depressed? Then you need to do counseling. That will take care of your depression, which will lead you to drink less alcohol. And people will say, oh, see, it's all about the alcohol, right? No, got to get to the root cause, the deeper understanding of why you're drinking alcohol. Same thing with the calories. Got to get to that deeper understanding of what is it that's driving you to eat those calories, right? Is it hunger, right? So if it's hunger, because say you're eating foods that have very low satiety because they're refined, right? They take out the fat, they take out the protein, there's no satiety, you add a lot of sugar, it makes you hungry, right? So say you're eating because you're hungry. That's why your calories in is so high. Well, you got to take care of the hunger, not just say, oh, eat fewer calories. That's what the GLP-1s do. They reduce the hunger, which causes you to eat fewer calories, right? But you're attacking the root cause, not the calories. The Ozempic doesn't make you physically eat fewer calories. They don't say count your calories. It just reduces the hunger, so you eat fewer calories, right? So it's all tied in there, but the root cause is the hunger. And you can't decide to be less hungry, right? You can decide to eat less, but you can't decide to be less hungry. That's where the drugs are so effective. We know they're effective, but it's because it gets to that sort of deeper level of it's not first order thinking, which is the alcohol in, alcohol out, calories in, calories out, heat in, heat out, right? Those are all true, but they're superficial. Got to get to the
I always
cause.
I always tell the patients that, are you hungry or are you craving something? So if you're in the pantry and you're just like looking around, you're probably not hungry. Imagine if I gave you a plate of broccoli and salmon. If you would eat it, then you're hungry. If you're like, nah, then you're not hungry. Go do some push-ups and forget about that thought that you need to eat something at that point in time. You mentioned something very important, knowing your patient. So, is your patient stressed? Is because stress will lead you to cravings for shit food. Are you sleeping okay? I mean, right now there's a lot of people that they're not sleeping well. Their sleeping habits suck. And then they go and they say, well, I'm going to have a cup of wine because a cup of wine is going to help me sleep, which you're fucking up your sleep with that. It's not going to be very effective, no? And COVID-19. The pandemia, I mean, I see constantly in my clinic people in their 20s with anxiety, depression, and now this anxiety and depression is manifesting itself with cravings for the processed junk, which go with the point that you were mentioning about the dopamine and all this thing. So knowing the patient is key because you just mentioned, so, well, what's going on? It's not about me giving a medication or restricting. Why are you eating more carbs? Why are you craving this more shit? Well, maybe because you're not sleeping well, or it's because of this. So that is an amazing.
That's the thing that, so we were all taught, you and I, we're all taught in medical school. That's just tell them to eat 500 calories fewer a day. That's why it didn't work, because we didn't understand that it's about why they're eating the calories that they're eating, right? If sleep is the problem, fix the sleep. Don't just eat fewer calories, right? If you're on night shift all the time, well, then you have to do something about that, about the sleep, about the circadian rhythm. Same thing with COVID-19. If the problem is that you're a bit depressed, and we saw this a lot. So COVID-19, everybody's locked down. Well, all of a sudden, you're not getting the things that make you happy. Hanging out with friends, playing ball, doing this. So then you went and got your reward, right? Dopamine from something else. And the only thing was food. So it was sort of a disaster for weight gain and diabetes and stuff, because the only thing you could do is eat. So therefore, in order for people to, to satisfy their need for the rewards, they ate because there's nothing else. There's, instead of going for a nice walk in the park with friends or playing baseball, right? Because that's fun. It's rewarding. It's fun. Now you have no baseball game to go to. You're not having that reward. So you go, I'm going to get my reward by eating this ice cream. Well, that's fine. You say, well, it's the calories. Like, well, yeah, but that wasn't the reason, right? The reason was that they didn't have that enjoyment, that they're looking for some kind of, some enjoyment there. And they had to get it from food as opposed to everything else, which was shut down at the time. So now it's different. It's about that, really, really understanding. And I think that's where it's always frustrating when people say, well, it's about the calories. It's like, it's hard to explain in a few seconds.
I was never successful. I mean, I have helped patients lose up to 100 pounds in a year, which if you ever told me that, I would have said not possible. And when I was telling them to count calories, and when I was counting calories, I even struggled in losing weight. I was even gaining weight, and it was just, screwed up knowledge,
Yeah.
Now, I would like people. I mean, another very important point, and I've seen you talk about this, and I the first time I heard about it, it was in The Art and Science of Low Carb Living with Stephen Feeney and Jeff Volek about electrolytes. So they talk about a ketogenic diet, but of course, if we're fasting, if we're doing low carb, I mean, I know that there's certain recommendations that. That you mentioned. Is there a couple of things that you want to tell the people about the importance of electrolytes? For example, sodium, and it's let's look at it like the evil guy, and which brings me to a very important point with you, because salt is not just sodium. Salt is sodium chloride. So 6 grams of salt can actually be your 2.4 grams of sodium, and the rest is chloride, So how do you tell people, or is there a particular dosage that you recommend of sodium, potassium, magnesium, or what do you go with?
So those are the main electrolytes that we worry about, actually. So sodium, potassium, and magnesium. So those three are, so magnesium is different because a lot of us are now magnesium deficient for different reasons. I talk about it in one of my YouTube videos about why we're so magnesium deficient now. It has to do with sort of industrial scale farming. So if you compare foods from the 1960s compared to foods today, there's like 95% less magnesium in it. And so therefore, a lot of people are magnesium deficient, gives you cramps, gives you all kinds of problems. So that's why it's important to supplement that. For a lot of people, but in fasting, of course, when you're not taking anything in, it may be important to take some potassium also, just because, again, if you're not taking anything in, if you're not eating, then you're not getting any electrolytes. If you're used to a bit of potassium, then you can replace it. You do lose some in your sweat, obviously, and same thing with salt. So if you're going from, a regular salt diet to 0 salt, then some people might get a little lightheaded or something, so you can take some salt. There are supplement packs that you can take. I think Enzymedica is one that's coming out with some fasting electrolytes, and it looks very good. There's other ones that are mostly salt, and it's like, I always think, okay, well, there's one that I was looking at. It's like almost all salt. I'm like, okay, but why would you pay like $5 for a packet when the salt actually costs like 3 cents, right? Like that makes no sense at all. So it's the potassium and the magnesium, because you can always get salt, right? So, at thefastingmethod.com, where we help a lot of people with fasting, we'll often tell them, you can take supplements in terms of the magnesium, potassium. For the salt, you can take it as salt, directly. You could use something like bone broth, for example, as a fasting aid. So it's not a true fast, but it's easier to add salt to that than it is to add salt to your coffee, right? It doesn't really feel right. But really, if you don't take salt and you're not having any problems, then you might be okay, because your body is very smart, right? So if you are a little bit low in salt, and then the next day you eat a regular salt diet, your body will retain the salt that it needs to. It'll excrete the stuff that it doesn't. So, those are the 3 main electrolytes that we looked at. So you don't necessarily need to take it while fasting, because when you eat, just make sure that you're eating good, nutritious food, right? Like unprocessed foods, which you're going to have those. Magnesium might be the one exception to that, but the salt and the potassium are mostly. And make sure you're just not paying for a lot of salt, because salt is dirt cheap. And salt is salt. Like whether it comes in a supplement pack or not, it's sodium chloride, right? So try and get the other stuff.
When I was starting with this, and it's like I was starting with a low carb and the fasting, and I read about, because for me, telling a patient that they need 4 grams of sodium was, as a cardiologist, like, but I had a patient, and I have several patients, and it goes to some trials in Europe, which for me are very interesting. There gets to a point in which patients are getting furosemide, torsemide, all these loop diuretics, and they're excreting the sodium, which makes me wonder if they are being told not to eat sodium. And then, in addition, you have them on ridiculous dosages of furosemide, for example. I remember that I had and then that's the first time that I made this observation. So I told the patient to go low carb. I'm like, he was done. He's like, I feel miserable. I'm like, well, let's try something different. And I told him to start taking 4 grams for a little bit more of sodium while he was doing this. And he was on the diuretics. Holy shit balls. He peed 22 pounds in about 10 days. When you go to there's some European recommendations about people that are resistant to diuretics, and they are developing lower extremity edema despite high doses. There's some doctors, nephrologists, and over there, they're giving hypertonic saline in addition to diuretics in order to promote diuresis, which, that is like...
Yeah, the whole thing about salt, other than if you're in like end-stage disease, like end-stage kidney disease, end-stage heart disease, it's very interesting, because we've always been told to eat less salt because it'll lower your blood pressure. which is probably true. But if you look at the magnitude of how low it reduces, it's like, 1.2, 1.5. So if your blood pressure is 142, it might go to 140 if with severe salt restriction. But remember that if you're restricted in salt, then what happens? Well, your body is going to respond to that, right? And what does it do? First thing it does is it raises sympathetic tone. That's the first way it does to try and reclaim more salt. And second, it's going to increase renin-angiotensin. Okay, so you've got a heart patient. Now, how do you treat heart patient? You try to block the sympathetic, beta blockers, and you try to block the renin-angiotensin system with ACE inhibitor, right? That's well-established medicine for the last 50 years, at least, right? So think about it. You have a heart patient and you're salt restricting them. You got a mild, minor reduction in blood pressure, which you could do other ways, but you've got a big increase in your sympathetic tone and a big increase in your renin-angiotensin system. So therefore, when you look at hard outcomes, you actually cannot find hard outcomes in terms of heart patients, in terms of reduced cardiac mortality, which is why the Institute of Medicine actually said we actually shouldn't be restricting salt in heart patients, because we don't know that it's actually beneficial. It might be actually quite harmful because you're revving up these other systems. Because people treat salt restriction as if it's a free blood pressure medication, right? Free of side effects. It's not. Your blood pressure goes a little bit down, and your sympathetic tone goes up, and your renin-angiotensin goes up, both of which are bad for heart patients. 100% we know that because we use drugs specifically to lower those. And now you're revving them up. So there's actually a lot of studies that show that low salt diets might actually be quite detrimental in heart disease patients.
There are studies, and you just need to sit down and see what the hell you're doing, because as you said, yeah, you increase the sympathetic tone, and then you're going to release more aldosterone. What the hell are we going? We're giving aldosterone receptor blockers in people with heart failure. So it's like, I mean, we have to question a little bit more about this. I mean, it's a fascinating talk, and I think we would be going a little bit more to another thing. I mean, it's almost 1 hour and 15. I don't want to be taking more of your time. I do want to say one thing, that to all our listeners here, the reason that I also wanted to invite Jason Fung, I mean, I've known him for the last, I think 6 years ago, it was the first time that we, I constantly see people basically quoting his book, basically saying the studies that were mentioned, and people, they look at this influencers, they look at this people like they're the ones that came up with this. And honestly, I think that, we've got Atkins and we've got, stories from the 1800s and stuff. But I think the first one that at least I know that basically put together a low-carb diet with fasting, mimicking the effects of a ketogenic diet came from you. So I wanted the people that are here in social media to know that. If you speak English, great. I mean, he's got the books. I mean, I doubt that you don't know Jason, but it's the Obesity Code, the Diabetes Code, and the Guide to Fasting. And any place, I'm not sure if you are, I don't think you're in TikTok, are you?
Not,
where can they find you?
But mostly you can find me, so the books, and they're all available in Spanish language. And also YouTube I have a lot of YouTube videos. Just look under Jason Fung. There's more than 100 videos, I think. And so YouTube is great because it's all free. You can watch it whenever you want. And there's all the different topics on fasting, all the different topics about the science and so on. There's some longer videos even. There's like hour-long lectures that are actually very high level. They're actually given to specialist physicians. So I tape some of them and put them online about diabetes, about some of what we talked about. So there's basic stuff like 10-minute videos on, fasting, different topics of fasting tips and stuff, different types of fast, beginning fasting, what to expect when you start fasting, that kind of thing, all the way up to stuff that your specialist physician wouldn't even know, because these were, for the Obesity Medicine Association talks and stuff. where I was a keynote speaker. So it's all there on YouTube. You can also follow me on Twitter at Dr. Jason Fung. And thefastingmethod.com is our program where we provide sort of, fasting is fine if you want to do it, but it's not always easy to stick with. It's not always fun. So having community, having an expert, having a coach might be very useful because, people have all kinds of coaches, like personal trainers, they have life coaches, they have business coaches. Why? Because it's useful to have somebody there helping you. So that's what we provide at thefastingmethod.com.
And I don't know, motivation. You've seen so many patients. You've got your groups in which you help people. You have patients that lose the weight. Any motivator, key words I can tell them to, get some hope? Because I think a lot of people, at least here in McAllen, as I said, the most obesity in the United States. People, I think, would appreciate the words from you for hope.
Yeah, I think that what you have to understand about fasting particularly, because, I wasn't the first to talk about low carb, but fasting really, I was probably one of the very early ones, especially in the medical profession, to talk about it, that it's okay. But fasting is, it's free, right? So you don't need anything to do it. You can get all the information from YouTube for free, from this podcast for free. But the other thing is that people can do it because, people always think, I can't do it. Well, people have been doing it for thousands of years. You look back at all the major religions, there are periods of fasting. People got through it. Was it fun? No. I'm not saying that it's fun, but you can do it because your health can really improve. Or you could reverse your type 2 diabetes, and maybe you could save a lot of money because you don't have to buy all the medicines, right? So there's different things. And sure, it's not as fun as eating, pizza and French fries, right? But on the other hand, if you choose, this is something that's available to everybody. You don't need any special equipment. You don't need any special clinics. You can do it yourself, and it's completely free. You can do it if you want, do it not if you want. You can get yourself into groups and say, we're going to form a fasting group and, with some friends, and do it for free because you can help each other, right? That's the secret of how people did this in the past. They did it with their church. They did it with their community. On this day, we're all going to fast, right? Then guess what? It's not fun. It's still not fun, but it's easy to do because everybody's doing it. And it still doesn't cost you a penny. It doesn't put any, I don't need to take your money. The drug company doesn't need your money. You keep your own money, right? But you're going to get healthier and you can do it. It just means getting the right information and organizing yourself. There are online groups too. We have a Facebook group that at the Fasting Method, which is free, and people talk to each other on it. Nothing beats in person. I think that's the other lesson of COVID. So if you do have friends, families, you do it together. It's a very, very powerful medicine that you can use for obesity, for type 2 diabetes, and it's there. It's there in the palm of your hand. Now you just have to figure out how you're going to make it work. And oftentimes that means getting together with other people.
Yeah. I definitely, it starts by you knowing that you are the one that needs to make the change. You have to, people need to be motivated. You have to, first of all, say, I want to change. Because if the patient doesn't want to change, get him to do something is going to be impossible. Yeah. And understanding about the pillars that can improve and can make you feel healthier: good sleep, exercising, what you're eating, are you meditating, are you relaxing, are you stressed, are you sleeping well? All those things, they're a web of variables associated with everything that we're speaking here. And as I said, once again, Jason has this ability to simplify the concepts, digest them, and give them to you. And when sometimes, people like him or I, we get criticized because we oversimplify things. As you can see, it's not that we do not understand the science, is that we're not aiming to be educating physicians or healthcare providers. We're here to educate the people so they can actually make the changes that sometimes we didn't even understand the literature that was fed to us because it was freaking wrong, So, Jason, I know in the past you also, when I was with Ariel Ortiz, because we have that other podcast, but you do have some posts that we were talking in the past about making them in Spanish or something. If you have anything that we can use to help the Spanish community? I mean, it's something that maybe I just need to, I don't know, retouch or something like that. But anything that you have?
I don't, we did that for a little while. Then I think some, stuff happened and I dropped it because initially I was translating a lot of the posts into different languages. But they weren't landing in the right place, I guess. So there was getting very little traction. But certainly, we have I've written a lot of blogs, right? And they all contain a lot of useful information. And perhaps it might be worthwhile to see where we could.
Well, the knowledge is there. You've done it. Maybe we can even consider about using something like HeyGen or AI, and it basically can translate your videos already in English, and it's you speaking in Spanish. And the reason I say that is, once again, this is the most obese city in the United States. One of the goals that I have said in the past is I want to drop it from the top 10 in the United States. And that is an interesting goal and mission that I have. So
yeah, maybe we should think about it, because right now I don't have anybody to do that. But maybe if we could get somebody to translate. I mean, there's the YouTube videos as well that are in English, and I don't know if it'd be easy or not to change them, either subtitle them or dub them over in Spanish and just post them on a different. I could create a new channel and just have it for Spanish, right? For example, and then again, everything's free and in Spanish, right? It's an AI might be able to translate or something. Google Translate, I hear, sucks, but
No, you got to check HeyGen, because I'm not kidding. You can get your video in that same video, and now you're going to be speaking in Spanish. It's quite freaky. I mean, your tone of voice is like it. So it's something that I'm exploring as well. But food for thought, because I think there's a tremendous community, because I said McAllen is Mexico. Yeah, it's in the United States, but it's Mexico. It's Spanish speaking. So I think there's a lot of potential to help people.
Yeah, maybe we should do that. Maybe we should talk.
Yeah, definitely. So it's a great place to end up the combo. Once again, thank you so much for everything that you do, for being here with us, sharing your knowledge. It's been a true pleasure, and we'll be in contact.
Great. Thanks so much.
Okay. All righty, man. Have a good one.
Yeah, you too.
Bye-bye.